congressional briefings to inform on the drivers of maternal mortality and legislative policy to improve maternal mortality and eliminate the Black-white disparity gap. Additionally, she serves in several leadership roles promoting efforts to achieve health equity. She has served in local and national leadership roles and has received many accolades for her clinical, academic, and community service contributions. Without further ado, I'll pass the mic to Dr. Veronica Gillespie-Bell.
Thank you so much for that kind introduction. I'm so happy to be here with you today and excited for our discussion. And so today I'm going to be talking about quality improvement through a lens of equity. I have no disclosures related to the content of today. And today what we're going to do is try to understand how quality links to equity. We're going to talk about the importance of looking through a lens of equity and talk about those barriers that keep us from providing equitable, respectful care, and then identify practical steps that we can take in quality improvement to support equitable and respectful care through quality collaboratives. So just to make sure we're all on the same page, so there's some definitions that we kind of throw around, and so we want to make sure we understand these. So we talk about health equity, we're talking about the absence of avoidable or remedial differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically. So the removal of those avoidances so that everybody can achieve health. And we talk about health disparities. Those are the differences in healthcare quality, access, and outcomes that adversely affect members of a racial or ethnic minority group or socially disadvantaged population. And so we can't separate equity from disparities. Health disparities are the way we determine if our care is equitable. And so to address health disparities means we are improving our equity. So if we think about what quality means, and this is a definition from the Institute of Medicine, it is the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. Now, the Institute of Medicine initially said there are 5 domains that get us to quality. Care has to be safe, it has to be effective, patient-centered, timely, efficient. Then they came back later and said, you know, really we're missing a 6th domain. It should be equity. Equity should be a part of these. Then they came back later and said, actually, equity has to be woven into all of these in order to get quality. You cannot have safe care if it's not equitable. You can't have effective care if it's not equitable, and so on and so forth. And then again, the way that we determine if we're getting to that area of equity is looking at our health disparities. And we'll talk about some of the ones that we have in the United States in just a minute. But from Braverman, health disparities are the health outcome that measure our progress towards health equity. So another terminology that gets confused is equality and equity. So equal care is not equitable care. We're not trying to give everyone the same care. We're trying to make sure everybody has the same quality of care. This is a visual depiction that I'm sure you've seen. This comes from Angus McGuire. And on the left, we see what equality is. This is everybody getting the same level of resources, getting the same care. Well, for the first guy, that's too much care. For the second guy, that's just enough. And for the third guy, even though he's gotten the same amount of care, it's not enough for him to get to his outcome, which is overlooking the fence, or for our purposes of achieving health. What we're trying to get to is what we see on the right, where everybody gets the same quality of care to get to that same outcome. There is a third iteration of this picture where the fence is gone completely, and that is liberation, where we have no barriers. So equitable care is the same quality of care. What we're trying to do is what is circled here in the middle, and that's to narrow our Black-white disparity gaps for a lot of these outcomes that we're talking about. And in order to narrow that gap, we have to make sure that everyone is achieving the same quality of care. So what do we see when we look at disparities around the country? If we know that health disparities are the way that we measure that we're providing equitable care, what do we see? Well, we know nationally that Black women are 4 times more likely to experience a pregnancy-related maternal mortality compared to their white counterparts. We know that the rate of preterm birth amongst Black women is 50% higher than that of white women. We know that infant mortality rate for Black women is 2.3 times higher than that of our non-Latino white infants. And even when we start to adjust for socioeconomic factors, we still see disparities. We see that the severe maternal morbidity rate for a Black woman with a college degree is twice that of a white woman with an 8th grade education. So all of this speaks to the point that we have inequitable care. Let me also be crystal clear, because I think sometimes this gets lost in translation. Race is not a biological condition. So Black women are not biologically predisposed to die in childbirth or biologically predisposed to have preterm babies or experience a severe maternal morbidity. It is the inequity in systems that have affected those outcomes. And so let's delve into why we have inequitable care. We all have taken an oath to provide the best care and to achieve outcomes. So why do we see inequities? So going back to definitions and making sure that we understand this, so there is a difference in health disparities and health care disparities. So health disparities are those outcomes that we just talked about, while health care disparities are the differences in how we deliver care. Now, what I mean in the differences in how we deliver care, there's plenty of examples that we have. We know that Black individuals are less likely to be offered preventive services such as cancer screening and flu vaccine. Black individuals are less likely to have adequate treatment of pain. Black and Hispanics individuals are less likely to receive cardiac or bypass surgery, even when it's medically indicated. And women are less likely to undergo appropriate cardiovascular testing. Now, these are not specific to maternal care, but it just shows how even when there are standards for how we are to deliver care, we deviate from those standards. It's known, it is a standard that from this time of the year, September, until usually around January or February, we are supposed to offer everyone the flu vaccine. So why does that not happen? And I would pose to you that it's because of something called implicit bias. So if you're not familiar with implicit bias, or you don't know what that is, implicit bias is also known as unconscious bias. So it is defined as the attitudes or the stereotypes that affect our understanding, our actions and decisions in an unconscious manner. And I've highlighted unconscious to highlight the fact that this is something that is happening without us even thinking about it, thinking about biases. Now, here's a very stark difference to just kind of make you understand from a non-medical way what I mean about bias. So if you look here on the left side of the screen, this is the Black Lives Matter movement, and this was in on June 3rd. And you can see that these individuals are kneeling, they're not aggressive, but you can see that just the fact that they were congregating, they were met with police in riot gear. Now on the right, you see that this is the Capitol Police during the riot on the Capitol on January 6th. Now you can see that most of these individuals are not individuals of color, and they are met with police in regular uniform. So what does that say about society and how we see those people differently? Well, on the left, if we see these are mostly people of color and the way that the police are dressed, that says our societal bias is that these are people that when they're gonna congregate, they are going to be aggressive, and we need to be prepared for that. Whereas when we see people that are people of non-color, white individuals mostly, that those individuals are met with police that are not quite as prepared for what would be a violent event. And so this is just how we see, again, just an example of bias in society. Now, before we start bashing society for having biases, let me just remind you and acknowledge that each of us have biases. And just for a moment of reflection, just to test this out. And if you know the answer, feel free to put it in the chat. A boy and his father are driving down the road and they get into a car accident. The father is killed and the boy is taken to the hospital. It's determined that the boy needs surgery. The surgeon comes out and says, I cannot operate on him. He is my son. And so the question is, who is the surgeon? And so I'll go through that one more time. A boy and his father are driving down the road and they get into a car accident. The father is killed. The boy is taken to the hospital and it's determined that he needs surgery. The surgeon says, I cannot operate on him. He is my son. And so the question is, who is the surgeon? And so feel free to put that in the chat. I see one person, two people. Yes, and so the answer is the surgeon is his mother. When I tell y'all that I operate every single Tuesday, taking out fibroids, hysterectomies, all of these things, I did not think that the surgeon was his mother. I started thinking, obviously, this is a homosexual relationship and he has two fathers. People should understand that we have all types of relationships. And I totally did not get that the surgeon was his mother. But that just speaks to my bias. Probably my first interaction with a surgeon was probably on television and it was a man. And so in my mind, when I hear the word surgeon, I automatically think about a man. And so when we think about biases and those biases being formed, we understand that biases are the way that our brain develops shortcuts. We are inundated with all of the amount of information that is coming in at one time, and we cannot possibly process all of that information. And so our brain likes to take shortcuts to be able to process information quickly and not have to use all of our brain power to process every amount of information that's coming in. Well, to process these or to make these shortcuts, we seek out patterns. And these patterns are formed by experience and social conditioning. So again, just for me, myself, my shortcut or my pattern is that surgeons are men. So when I hear this word surgeon, and that's again because of my experience in social conditioning, probably through television, because I had not really seen a surgeon until I was in college and shadowing my OBGYN, and he was a man. But so I really did not see a female surgeon until I was in medical school. So by that time, my experience in social conditioning has already told me that when you hear the word surgeon, you think man. So we all have biases because our brains automatically take these shortcuts. The problem is how we as healthcare providers, how these bias manifest in how we deliver care. Just to give you another example of bias and to give you that example from a medicine standpoint, on the left side of the screen, this is Marion Sims, known as the father of modern gynecology. He invented the speculum. He invented the procedure that repairs vesicovaginal fistulas. He did all this, though, by operating on slave girls. There were four in particular that are named, but he did this by operating on slave girls and women. And even though anesthesia was available at that time, he did not give them anesthesia while he was operating on them. And so what came out of that is that Black people don't feel pain in the same way. And so that bias has perpetuated over time and is now the fact for some people. And so what you see on the right is a study that was done at the University of Virginia. They surveyed 222 white medical students and white residents, and over 50% of them believe that Black individuals do not feel pain in the same way. They believe that Black individuals either don't have nerve endings that are the same or their skin is thicker. And the higher their belief was in what is not true, but the higher that belief was, the less likely they were to adequately treat the pain of their Black patients. And so this is just an example of how bias becomes fact and how we then incorporate that into how we deliver care. Now, the other way we see biases manifest are in the way of microaggressions. So microaggressions are those comments, those actions that subtly and often unconsciously or unintentionally express a prejudiced attitude toward a member of a marginalized group, such as a racial minority. And there's three different ways that we see microaggressions. We see micro assaults, micro insults, and micro invalidations. So give you examples of those. A micro assault is a conscious and intentional action or a slur. So for example, my husband and I were in Florence, Italy, and my husband likes custom made suits. So we go into some suit place in Florence, Italy. And as soon as we walk in the door, the customer service representative was following my husband at his coat, like at his footstep all around the store, did not once ask him if he needed help, did not offer to help him. And so that store clerk was using a conscious action, even though he didn't understand that was his bias was my husband as a Black man must have been coming in here to steal. And so he needed to watch him. And so that's just an example of a micro assault. A micro insult is a verbal or nonverbal communication that subtly conveys rudeness and insensitivity that is demeaning to a person's race, their ethnicity, or their gender. One that I use quite commonly as an example, I remember this from 5th grade when someone in my class said, Veronica, of all the Black girls, you have the nicest hair. So what she was saying is that Black girls don't have nice hair, but I had the nicest of the ugliest. And so she thought she was giving me a comment, but in her verbal communication, it was conveying rudeness about my ethnicity and about different characteristics of my ethnicity. And then a micro invalidation is a communication that subtly excludes, negates, or nullifies the thoughts, the feelings, or experience reality of an individual. So an example for that, when people say stop Asian hate, and someone responds with stop all hate. Well, yes, nobody needs to experience hate. But when Asian individuals were afraid for their parents to walk out of their house and to go to the store because they were afraid that they were going to be attacked in these senseless acts of violence, to say stop Asian hate was something that they were feeling in that moment, because at that time it felt like there was a lot of hate towards Asian individuals. And so to say stop all hate, you're nullifying and negating the feelings that Asian Americans are experiencing in that moment. Now, these examples that I've used have nothing to do with medicine, but again, if we remember that we all have implicit bias, then we all display these microaggressions in one way or another. And we would be foolish to think that we walk into the hospital setting and just all of a sudden turn these off. We don't. And so our patients begin to feel this. And so when we think about equitable care is respectful care. So if we are displaying these biases and these microaggressions, it's very difficult to make sure all of our patients are receiving respectful care. So just some examples that have been in the news. An inmate gave birth alone in jail. And this happened not just in this story here in Florida, but also in Texas. This also happened in Denver. So are these individuals receiving respectful care? Two more examples. So Alicia Liggett, Dr. Liggett, is a family medicine doctor, and she talks about the day that she was reduced as a Black birthing body when nobody explained to her or talked to her during her birthing process what was happening. And then plenty of people have heard about Serena Williams, who had a history of a DVT and was having shortness of breath after she had a baby, went to the nurse's station and said, I'm having a pulmonary embolism. I've been through this before. And they told her, you're fine. Shortness of breath is normal. Don't worry about it. And it wasn't until she demanded a CT they were able to find that pulmonary embolism. So did they experience respectful care? Were their voices heard? And I like these two quotes on respect, just in general. We think about respect, and then how that manifests in respectful care. Jackie Robinson says, I'm not concerned with you liking or disliking me. All I ask is that you respect me as a human being. And then Lawrence Stern says, respect for ourselves guide our morals, and respect for others guide our manners. So again, in thinking of how we are treating our patients and our colleagues as well. So respectful care is patient-centered care. And so the Institute of Medicine defines this as providing care that is respectful of and responsive to individual patient references, needs, and values, and ensuring that patient values guide all clinical decisions. Picker has actually 8 principles of what patient-centered respectful care is. That means respect for patient's preference. That means we don't roll our eyes when our patient comes in with a birth plan. That means coordination and integration of care. That means information and education, understanding that our patients are informed consumers. And so we have to give them information and education so they can decide and have some say in how their care goes. Physical comfort, emotional support, involvement of family and friends. And I would add in here doula and midwife, continuity and transition, and then access to care. And so again, we all want to have our patients to have the best outcomes, but there are obstacles to that respectful care. We've already talked about bias, but just a few other obstacles. The culture of the healthcare system also can dictate whether or not respectful care will occur. Time is a barrier, and then we'll talk about the respect model as well. So we think about that respect within, or the culture of a healthcare system. We think about respect and we think about equity. In a culture of respect, people perform better, they're more satisfied, they're innovative, they display greater resilience. And this means respect for not just our patients, but respect for our colleagues as well. And then we think about culture and equity. Equity has to be an integral part of our values within our healthcare system. That means acknowledging disparities and then viewing them as injustices when inequities happen. So you have to have respect and equity in the culture of the healthcare system to get to respectful care. So how do we see disrespect in healthcare? And I won't go through each of these, but I just want you to review the slides in your own time and just think of how many times you've seen this happen in the last week within your healthcare institution. That passive disrespect, those nonverbal insidious behaviors, rolling eyes, sighing, glaring, staring. We don't often see disruptive behavior, but we do see demeaning behavior, insensitive jokes, things like that. All this, it creates a culture of disrespect. And if there's a culture of disrespect amongst the people that work within the healthcare system, it's really hard to then have respect given to the patients. And then if we think about equity within the healthcare system, what does your healthcare system look like? This is just one example when we think about the lack of diversity in the healthcare system. So this is from the American Association of Medical Colleges, the AANC in 2018. They surveyed over 42,000 active physicians, and they found that Blacks account for only about 5% of all active physicians, Hispanics only 5.8%, and most of those physicians are male. So what does that say about equity when quite often the diversity amongst our providers does not look like the diversity that our patients of patients that we see? And then thinking about leadership, this is from Korn Ferry. Of 200 hospitals and health systems surveyed, 55% reported that they overlooked women for executive leadership positions because they were women. And almost 80% of the healthcare workforce is involves women, but only 19% of hospitals are led by women, and only 4% of healthcare companies have a female CEO. So what does that say about our culture of equity in our healthcare system if we are lacking the gender diversity in our leadership as well? So moving through our barriers, time is a barrier. So this is another study. It showed that 27% of OBGYNs spend about 17 to 24 minutes with their patients, 35%, 13 to 16 minutes, and 27% only about 9 to 12 minutes. And this is not because physicians don't want to spend time with their patients. There are all these external factors around time that make it so that we don't have the time that we want with our patients. In fact, physicians report the lack of time with their patients causes decreased job satisfaction and physician burnout. And then the respect model. This means having rapport with your patients, expressing empathy, having support, partnership, explanations, cultural competence, and all this develops trust. And so this is how we get to the respect model. So what is our pathway to change? How do we get from disrespectful care and inequities to respectful care to then get to equitable services and equitable care? Well, when we look at the pathway change, this means we have to involve healthcare providers, our patients and our community partners, the healthcare system itself, and policymakers. And we're going to go through each of these, and I'm going to give you some tips and tools and things that you may be able to apply in Colorado. Excuse me. And we have to remember too that perinatal quality collaboratives, we really do intervene with all of these different entities, and we have a strong influence on change. So healthcare providers. So change starts with me. And so I love this quote from Gandhi, who says, "Be the change that you want to see in the world." So 60%, and this came from a study from Harvard, 60% of providers believe that the quality care is different by race, but only 40% thought that the difference applied to their patient panel. So we have to do that internal work of understanding that we all have biases, understanding what your bias is. If you've not taken the implicit association test, or if you've taken it before, take it again. This is a free test through Harvard, through Project Implicit, and you're able to test to see what your biases are in different ways. You may not have a bias that is race related. It may be gender related. It could be size related, but you're able to go through and figure out where you may have biases. And really acknowledging your bias is the first step. Once you do acknowledge that you have a bias, then you can begin to address it. And Patricia Devine is a social psychologist, and she has the only published study that I know of that shows that we can effectively turn our biases around. But we have to remember, again, I highlighted that word unconscious. Our biases are unconscious, and so it is very difficult to turn them around. It's really like undoing a habit. If I was a smoker, today is Friday, I'm smoking, I wouldn't say, okay, by Monday, I won't be smoking anymore. That's unrealistic. I have to work intentionally at that habit to change it, and biases are not different. But when you're working through those intentional processes to undo those biases, part of that is seeing people as individuals. When I see Veronica in everything that Veronica represents, not necessarily Veronica is a Black woman and then all of the things that I think Black women represent. It's recognizing that if you have a belief towards a gender minority or racial minority, towards any minority, that belief is based in stereotype. You have to increase your opportunities to have contact with individuals from different groups. As I mentioned, for me, I didn't have opportunities to interact with female surgeons until I was in medical school. But by starting to increase those opportunities, you start to think of those roles differently and start to think of those biases in a different way. And then above all, having empathy, putting yourself in someone else's shoes. And moving through respectful care and patient partnership. This is a huge, huge component to undoing biases and to changing the culture of a healthcare system. We have to keep patients at the center of innovations of care. And Latasha Rouse, who is a patient partner guru out of North Carolina, has a quote that I love and put in most of my presentations. Family-centered care is not something you do for a family. It is something that you do with a family. So we have to see, again, our patients as partners and help them to guide us in how we deliver care. And then there are ways that you can see what your care is like. These are 3 validated tools to measure respectful care: the Mother's Autonomy and Decision-Making Scale, the Mother's on Respect Index, and the Mistreatment Index. These are validated tools for you to evaluate what the patient experience is like, but I have also some qualitative ways for you to measure that we'll talk about in just a minute. And what does that look like, having a partner, a patient as a partner in decision-making? Well, if we think about medicine, for the most part, it's prescriptive. The healthcare provider has all of the knowledge. I make the plan, you're the patient, you didn't go to medical school, you follow the plan. This is traditionally how we have been taught. This is a very paternalistic method that we're taught through medical school and through residency. And we really need to move from that to shared decision-making model. The healthcare provider and the patient develop a care plan together. Now with that, the patient's roles and responsibilities are still not really included. And so when we get to partnership, we really are having a mutual agreement on the plan and the decisions, including a shared accountability. And from healthcare systems, we have to look at different pay models. We have to move from volume-based care to value-based care. That is how we add time back into the provider's schedule to be able to give patients the amount of time that they need. And we have to create systems that promote a culture of respect. That means accountability for those disruptive and disrespectful behaviors that we discussed earlier. What is the accountability when that happens? We want to engage and support. And again, we want to partner with our patients and families in helping us to reshape how we deliver care in the healthcare system. And for policymakers, they have a huge influence on being able to develop policies that will promote respectful care. I've just included a couple here, but there have been maternal policies that will require implicit bias training for physicians, nurses, and allied health professionals out of California. And so this is, again, looking at our maternal policies through a lens of equity to see if there are ways that our policies are being unfair and causing disrespect. We have the Black Maternal Health Momnibus. We have to grow and diversify our perinatal workforce to ensure that every mom in America receives culturally congruent maternity care and support. Just as an example, here in Louisiana, we have Act 210 that passed within our last legislative session, where we are creating a doula registry to then in the near future, after the registry is created, to be able to ask our insurance providers to ensure doulas as a covered service. Right now, yes, doulas, we know that doulas help to improve outcomes and are advocates for patients when they are in the hospital. They do a lot of home visiting, so they see patients in their own environment. But in a lot of states, doulas are not a covered service, and so only those who can pay out of pocket can benefit from that service. So just more about our role in Louisiana with the Perinatal Quality Collaborative and the Pregnancy Associated Mortality Review, and what we have done in Louisiana to have an emphasis on equity. So the Louisiana Perinatal Quality Collaborative launched in August of 2018. At the same time that we launched, we released our Maternal Mortality Review Report, which was reviewing maternal deaths from 2011 to 2016, only looking at pregnancy-related deaths up to 42 days after delivery. Now, we no longer review in that way. That was an effort to get a quick review done because there had not been a state review for 10 years prior to that. We now do review all maternal deaths, regardless of the cause, up to a year after the termination of pregnancy. But again, this was a quick review to just figure out where we were as a state. And so in this review, they found that the leading causes of pregnancy-related deaths were hemorrhage and hypertension. They also saw there was a disparity where 4 Black women were dying at a rate of every 1 white woman. And so for us, through the PQC, we are the action part of that data to action interaction. And so our action part, our first initiative was the Reducing Maternal Morbidity Initiative. And our aim was to have a 20% reduction in severe maternal morbidity from hemorrhage and hypertension between August of 2018 to May 2020, but also to narrow the Black-white disparity gap. So I show this slide because this was a very controversial way to go about our first initiative. Even on a national level, even thinking about AIM, no one was incorporating equity into the work that they were doing. Think about AIM. Equity came out as a separate bundle altogether. Hemorrhage was a bundle, hypertension was a bundle, VTE, sepsis, and then equity came out as one all by itself. I don't know if our work influenced this change, but now equity is woven into all of the bundles. And remember, it's just like I was explaining with the Institute of Medicine. You cannot get quality, you cannot get to quality without incorporating equity. And so we did decide that this was going to be our charge and that we were not going to shy away from it. It was an uphill battle. Many people, if you've heard me talk before, I've talked about this. When we use the BTS model, the Breakthrough Series model through the IHI with learning sessions, our second learning session through the RMMI was around health equity. And we met with our teams and we were simply talking about some of the things I've talked about with you today, the differences in equity and equality, healthcare disparities and health disparities. And 2 of our hospital teams felt offended that we were having the conversation and walked out of the learning session. Not during the break, in the middle of us having the panel discussion. And so we had a decision to make. Were we going to worry about those that we were offending by having these conversations, or were we going to dive in and do what we thought was right? And we decided to dive in. And so we continued to talk about equity and make it the fabric of what we do. So we design equity into our activities. We always use a driver diagram for all of our quality improvement. And we really believe that whatever we are trying to get to, no matter what our initiative is or what our aim is, our driver diagrams are really made of 4 key areas: reliable clinical processes, respectful patient partnership, effective peer teamwork, and engaged perinatal leadership. So those reliable clinical processes, these are the things that we're going to be familiar with from the AIM bundles: quantification of blood loss for hemorrhage, timely treatment of hypertension, all of those things. That's great, and we need those reliable clinical processes, but we also have to have respectful patient partnership. We have to design for partnership and invest in the improvement. That means transparent communication for trust. Also having that effective peer teamwork, addressing those microaggressions, creating that culture of respect. And of course, we have to have perinatal leadership that's invested in resources for that change. And in creating that culture of equity, again, we have made equity a priority. We did not shy away from those conversations and have doubled down on creating the culture of equity. We had the learning session on equity. We have we talk all the time about equity with our teams. When COVID-19 deaths were starting to happen at the beginning of the pandemic, Louisiana was one of the first states that started stratifying their data by race and ethnicity. And that's when the country realized we have a disparity here. Black individuals are dying at a rate higher than their counterparts. And we talked about that with our teams, understanding that the drivers of those disparities in the maternal health outcomes are the same drivers for the deaths in COVID-19. It doesn't matter what that health outcome is, the foundation is going to be the same. But again, having those conversations with our patients, with our hospitals and with our teams. We make equity a priority by having it as a part of our charter chats. So with our teams, we meet with them on a quarterly basis, and we do charter chats to develop a 30, 60, 90-day plan. So what do I mean by charter chats? So we always have our aim that we're working on as a hospital, as a quality initiative or quality collaborative, but each individual hospital will have an aim that they are working on to get to that ultimate aim. And you can see here from this charter chat, not only do they have their aim they're working on, but they have to have a patient partnership and equity goal. And then we help them figure out what can they do in 30 days, 60 days, and 90 days to get to that aim of what they are trying to accomplish. And so again, we make it a priority to talk about it. And before I go on from here, I did not include a slide, but just to let y'all know that for our MMI initiative, for our final results, we did reduce severe maternal morbidity from hemorrhage by 35% and by 49% in Black women. We saw a reduction in severe maternal morbidity from hypertension by 12%. Now, before the pandemic, that reduction was 22%. And so I do think that the pandemic affected our outcomes. We do now know that patients that have COVID-19 in pregnancy have an independent risk factor for also having preeclampsia. And then we also know that pregnant individuals with COVID-19 have a higher risk of intubation, mechanical ventilation, and death, all diagnoses that will trigger a severe maternal morbidity. But just to let y'all know about what our results show for there, although discussion is focusing on equity. And then the final way that we make equity a priority is through something that we've just developed, our Louisiana Birth Ready designation. So our designation distinguishes those birth facilities that are committed to practices that promote a safe, equitable, dignified birth. And so there are 5 key areas that we ask our hospitals to report on. And you can see that one of those is addressing health disparities in patient partnership. So they have to, again, be working on ways to improve equity. And we have a menu of items that they can choose from, whether it be one of those validated tools that I discussed earlier, or they can do implicit bias training for nurses and providers with a debrief, so not just a check in the box. They can have a mechanism for patients and family to provide feedback that leads to change. A lot of our teams have taken this on, and they do just simple discharge calling. So patients that have gone home, hey, can you tell me about your experience? Not a yes or no question, but can you tell me about that experience? And using what the patients are saying to then drive change within their facilities. We encourage them as another option to have a patient or a family partner as part of the improvement team. And then also training the staff on family-centered care. And so in conclusion, respectful maternity care is necessary for quality and safety. You cannot have quality without equity. We have to recenter the work to the who and the why, and we have to make care equitable by making it better and consistent. And when I talk about respectful care and talk about equity, I always end with this picture. So this picture, the individual that's on the left, her name is Simone, and the individual that's on the right, her name is Latona. Latona is a nurse and also a doula. And so I don't know Simone, but I do know the author of her story. This is in the New York Times, who acted as her surrogate mother during her pregnancy, where Latona was her doula. So Simone had experienced a pregnancy loss around 18 to 20 weeks, and obviously it was a tragic event. And so for her next pregnancy, she decided she wanted to have a doula to help support her throughout the pregnancy and throughout her care. And for all intents and purposes, the way that we define a good outcome in medicine, she had a good outcome. She had a baby, the baby was born at term, mom and baby didn't have any complications, and she went home. And so we all pat ourselves on the back. She had a good outcome. But for our patients, the outcome is just the floor of what's supposed to happen. You are supposed to have a baby and have a good outcome as a mom and as a baby and not die in childbirth. So that's just the floor. And so when you talk to, or the way Simone has described her story, during the delivery process, individuals came in the room. They didn't introduce themselves. This was at a teaching hospital. Residents came in with medical students asking, do you want to check her? Not asking the patient or talking to the patient and getting her permission. She felt like people talked around her and did not talk to her. They did not make care plans that were involving her and with her. And so I think about Simone's birth story, and there was definitely a lack of equity and a lack of respect there. But then I think about my own birth experience. I had a great birth story. I delivered at the hospital where I give care. So of course, everybody already knew me. But I think about if I was not Dr. Gillespie giving birth and I was just Veronica, another Black woman in that hospital, what would my experience have been like? And so I like to leave with a comment that privilege should never be the gateway to respectful care. Whether that privilege be the color of your skin or the title that you carry behind your name or in front of your name, privilege should never be the gateway to respectful care. That is something that should also be the floor. Just as it is the floor to have a healthy mom and a healthy baby, so is respectful care. And so with that, I have a ton of references if there's anything else that you would like to read more about. And I am happy to answer any questions that you may have. Stop sharing the screen there.
Thank you so much, Dr. Veronica Gillespie. That was truly amazing. And for our audience, the slides will be available in the WOVA app. So you can revisit those as was mentioned during the talk. And we have a number of questions coming in. So I'm going to tee these up and let you take them on.
Sure.
I want to just make my screen a little bigger. So in Louisiana, how did your stakeholders respond to the phrase health equity versus racism? Was racism explicitly identified and stated? It feels like people are becoming more comfortable with working on health equity, but less comfortable so with racism in healthcare.
Yes, and I'm sorry, let me know if y'all can't hear me. My cleaning lady is backing me outside. So because of our 400-year history in the United States with race, Going back from 1619, the word race, it gives a very visceral response, and the word racism gives a very visceral response. And depending on someone's familiarity with the term, they start thinking Ku Klux Klan and white hoods, and that is not me, so do not say the word racism. And so you do have to understand who your audience is, and you have to understand where they are on their growth to equity, as to whether or not they understand these terms. And so quite often as I'm giving these discussions and I'm giving these talks, one of the things that I do is just what I've done with you guys, is just start out with just some basic definitions, because the word race and racism, as we've already mentioned, can cause individuals to immediately put up their defense, and they will not hear a word of anything else that you have said. Now, generally, when I'm giving this talk and talking about not necessarily equity, well, still talking about equity, I usually start out with the implicit bias and the story that I was telling y'all. And then people are like, okay, I can identify that with that. Oh, I could see how I have biases. And then we start getting into some of the other touchy terms as a way of making sure that we're engaging. But it is something that we've had to think long and hard about as far as our approach.
Thank you. Another question came in regarding, our healthcare systems and our schools of medicine. We're all increasingly aware of healthcare inequities and beginning to develop diversity, equity, inclusion programs or equity-focused projects. And so a lot of times, pretty much all the time, we charge people of color, those who are pegged as the disparities, and those providers with this work, and it can feel burdensome and excessive. Do you have any thoughts about how we make this better?
Yeah, so that is 100% true. It is 100% true. And so I think one of those things that we have to do is two things. We have to all become comfortable talking about race. There is a mnemonic that I use. I'm not going to probably remember all the different parts in the mnemonic. The mnemonic is race, and it's about talking about race to normalize it. It is accepting that for some individuals, race is very obvious, and for other individuals, race is not very obvious. And it's about, the C is about collaborating. And then the E is to make sure that you have examples and that you have a plan for what you're going to do with this information. We have to realize that when we do involve people of color in discussions about race, that it is releasing trauma for them. It is rehashing trauma. And so you're right, you do not want to continuously rely on those individuals. So you do want to think about who are your collaborators, who else can you partner with to have these discussions, whether that be someone that is trained in talking about diversity, inclusion, and equity, or being, I call kind of deputizing individuals. One of our CEOs at our hospitals talks about how the very first time she was having a kind of a fireside chat with her employees, and was like, I just don't want to say the wrong thing. I have a heart for this and want to see things better, but I don't want to offend anybody. And she said after she had that first conversation, she realized, okay, that was hard, but it was okay. And the more she started leading those discussions, she was like, okay, like I can do this. This is not as hard as I thought. So we have to, again, normalize it by talking about it. And so start deputizing and asking other individuals to also be a part of the conversation. It doesn't, like you said, it doesn't always have to be minorities. When we think about all the changes happened in our country, legislatively, thinking about Dr. Martin Luther King Jr., there were white people there just like there were Black people. So we have to remember to involve every discussion.
Thank you. Another question just came in. First of all, acknowledging your talk and thanking you for being here today. And could you talk more, or maybe give more examples of, you mentioned culturally congruent maternity care, and you mentioned doulas, for example. Are there other examples, and can you talk a little bit in more detail about that?
Sure. So a few things with the culturally congruent care. So there's data that shows when there's concordance of race between provider and patient, that there's a greater level of trust, greater level of satisfaction. And actually out of Florida, they showed a decrease in infant mortality for patients that were in the NICU. And so that's not to say that I, as a Black woman, cannot take care of white individuals or Hispanic individuals. That's not saying that, but there is a certain level of trust. And so that cultural congruency is just to elevate that and just to highlight that. And again, speaking to why it's important to have diversity in our staff, and not just in doctors, in our nurses, in our lactation counselors as well, our ILBC trained staff as well. And then thinking about expanding the perinatal workforce. We've already talked about, for physicians, there's not enough of us and we don't have time. So expanding that healthcare workforce to midwives, to doulas, to perinatal community workers that are going into the homes, looking at other programs like the Nurse Family Partnership Program, where it's a home visiting program that's done by nurses. So we have to think about how we look at healthcare differently. I quite commonly say we've built a healthcare system around the healthcare system and not around the patient, and bringing the care to the patients. And so expanding that healthcare workforce is about that, is about bringing the care to the patients and making sure that there is that cultural competency, so that we have that level of trust.
Yeah, that's great. And questions keep coming in, so I'll keep rapid fire.
Okay.
So one member of the audience is wanting to learn a little bit more. You had mentioned COVID, and how do you think COVID has impacted equity and respect in care, specifically in the maternal population?
Unfortunately, COVID has furthered our disparity gaps, is what I feel and what I see from a clinical standpoint. Now, the data is a little bit lacking. We don't have, or at least I don't know of data that is stratified by race and ethnicity in the way that we need it to be to show those outcomes. Again, we do know just in general that Black individuals have experienced deaths from COVID at a rate higher than that of their counterparts. And actually, Native Americans, I believe, are at actually the highest rate of COVID-19 deaths. But it has interfered with with prenatal care in several ways. Access has been an issue. We know that in the beginning of the pandemic, we were all on stay-at-home orders. And so a lot of us in the healthcare, as healthcare providers, started doing virtual visits and telehealth. Well, that's great if you're in a system where you have access to broadband and to all these things that you need to do telehealth. But if you don't already have access to that, to those resources, then what do you do? We also know that, oh, I'm sorry, I'm breaking up. Okay, sorry. I'm losing my voice, so that may also be part of why I am breaking up. And if I need to, I can turn off my camera if I need to increase my bandwidth. So just let me know if it starts to get crazy sounding again. But we also know that that Black individuals Black and Hispanic individuals, Black and Brown individuals were also quite commonly frontline workers and could not stay at home when there was a stay-at-home mandate in place. They were those frontline workers. And then we know for people of color, Black and Brown individuals, they also live in multi-generational households. And so that further increased the risk of developing COVID-19. So there was an issue from increased risk of developing COVID-19, which we know pregnancy itself increases the risk that you're going to have a bad outcome. And then there were issues in the way of access that also have impacted care. I think we're just now starting to see data around how much routine screening was missed during COVID-19. You can't do a gestational diabetes screening through a telehealth visit. And so, so I think we don't fully know what that's going to look like. And we're just now starting to look at the data around that.
Thank you. We have time for a couple more questions before we lose your voice, hopefully. Someone was asking, what approaches, if any, to using QI methods can address health equity? And, you mentioned some things like, I think, simply stratifying data. A lot of hospitals haven't even, they don't do that. And so I know at CPCQC, that's one thing we look at trying to do within each of our projects is, how can we measure outcomes, get a baseline understanding of the different populations that our hospitals and our outpatient clinics serve. What other things, what approaches would you have that folks here in attendance today could literally go take with them, take back to their care teams and start to implement?
Yeah, I think, like you said, the first thing is stratifying data by race and ethnicity. So then you find out where your disparities are. We already talked about that is the measure to know if we are achieving equity. So that being the first thing. And then really thinking about how you get your patient's voice and looking at those patient partnerships. Now, and again, if you want a validated tool, we have the three, the mistreatment index and the maternal autonomy and the maternal respect tool, where you can actually give that to your patients and you can see where your baseline data is around autonomy and respect, and then use that as we do quality improvement, use that data to do your action to design what your project is going to. Doing phone calls, discharge planning, doing those phone calls to find out what patients' experiences are like, and then use that to design the activity. Use an improvement science. You always want to do your plan, do, study, act. And you want to, as you get that data, plan out what your activity is going to be, do it. You want to study it by measuring, because as we know, all improvement is change, but not all change is improvement. So measure it to see if you're starting to see improvement, and then either abandon what you're doing because you're not getting the improvement that you want. You can adjust it or you can adopt it.
I love that. Many of the participants on the call, we've been really honing in on that in our learning collaborative is small tests of change, right? Don't try to boil the ocean. Start with one small test, maybe one patient, one provider, maybe one care team, get feedback from the patient. How did that feel? We're working on conversational screening. Were you comfortable? Is it better to do it electronically? Really just practice and test and then make modifications. So that was spot on, I'm sure, for many of the participants who are working in the learning collaborative and doing those PDSA cycles currently.
Yes, exactly. And, as I mentioned before, that's kind of what we work with our teams on that 30, 60, 90-day plan to help them do a small test of change. Everybody is not a QI guru and does not automatically understand what we're talking about. But if you were thinking about doing that, where you're doing soliciting patient information, your 30-day plan may be just what are the questions going to be? What are those questions going to be? Your 60-day plan may be, okay, we're going to now give this, we're going to actually see what the questions that we've developed as a team. Let's tell our our nurses and our providers, let's see how they think about these questions. And then your 90-day plan may be, okay, we're going to do this with all the discharge that goes for this one provider. But definitely doing those small tests of change, as you mentioned.
Yeah, I love it. Great advice. Perfect way to really hone in on what we're talking about today, which is listening to your patient and their needs, engaging them as part of the care team and a partner, and then being able to take action to make change. And to your point, not all change is good. So, not being afraid to try things out and see what works in true QI fashion. So I just want to thank you for being here today, this amazing talk, and for your partnership. We're just so fortunate to be part of the national network of PQCs and work with our state partners like Louisiana and others. And so I just couldn't thank you enough for this educational information, for sharing some great practical tools, and for being with us today.
Thank you so much for inviting me and for having me here. This was great. So I hope that everybody learned something. So thank you.
Yeah, and we'll see you again soon, I'm sure.
Yes. Bye, everyone. Have a great rest of the day.
Thank you. Thanks so much. All right, so we are at 10:45. And our next break is upon us. We are going to take time for a mindfulness exercise.